Recording in progress.
Good evening. Welcome all for this Series 3 of the MEND Clinical Update 2023. And today we have three interesting different topics in endocrinology, diabetology for better management of the three different aspects of the disorders. The first of the topic is on diabetic kidney disease. Second will be on obesity and obese type 2 diabetes. And third of the topic will be on the management of the osteoporosis. All these problems are quite common, quite often seen in our day-to-day practice. And with the advent of newer therapies for the management of these conditions, we can definitely help people in changing the natural course of these disorders to large extent. So first talk will be taken by Dr. Shyam Bansal. Dr. Shyam Bansal is Senior Director and Head in Department of the Nephrology at Medanta, the Medicity, Gurgaon. He will be speaking on the management of the diabetic kidney disease. And I hope that you will definitely learn how to help your patient and to improve your clinical practice. And I request you to ask as many as questions so that you can definitely gain some from his discussion. Second talk will be taken by Dr. Jasjeet Wasir. Dr. Jasjeet Wasir is Director in Division of Endocrinology and Diabetology at Medanta, the Medicity. Dr. Wasir will be speaking on the upstream approach of the newer anti-diabetic drug, that is GLP-1 receptor agonist. And these kind of the drugs do help people in management of the diabetes as well as losing weight, and newer approval for weight reduction has also gotten by these group of the drug. And definitely a kind of, I would say, a big enthusiasm about these newer group of the anti-diabetic drug is there. And I hope you will definitely learn how and where to use these drug and what kind of the all benefits you are going to gain from this drug in your kind of the patient. Third discussion will be by Dr. Parjeet Kaur. Dr. Parjeet Kaur will be speaking about the newer therapy for managing osteoporosis, a quite neglected condition, right? I would say very, very neglected condition. Osteoporosis, attention is not done there. And even what I often see is, despite having people sustain a fracture, treatment for fracture, some kind of the intervention being done, they are still not on the kind of the anti-osteoporotic therapy. So that's a big, big problem in the management of the osteoporosis. This is not considered to be a disease still by the large section of the people and even with the treating physician. So Dr. Parjeet is going to speak on the osteoporosis management with you. So for today's meeting, I have with me my colleague, consultant, Dr. Rujul Jain, who will be taking you through the program, who will be introducing all the speakers, who will be mediating the question and answer sessions, and I will join you in the end of the discussion today. With that, thank you. Over to Dr. Rujul for the conduction of the today's program.
Yeah, thank you, sir. A warm good evening to everyone. So we start with our first session of today's MEND clinical update. So as we all know that diabetes is the leading cause of end-stage kidney disease worldwide. And in the past few years, there has been an advent of many newer treatment modalities in the management of diabetic kidney disease. So to discuss about the management of diabetic kidney disease, I have the privilege of inviting Dr. Shyam Bansal, sir. Dr. Shyam is Senior Director, Department of Nephrology at Medanta, Gurugram. So I invite sir for his deliberation.
Oh, uh, 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 uh,
So, Dr. Rujul, I think it's taking some time, and I guess a lot of people might have logged in. So, I would request the admin to please get in touch with Dr. Sham on the phone, or maybe take control of his laptop and help him out there. Till then, I think I'll start my lecture so that everybody who's joined in stays on board.
Yes. So I think there is some connectivity issue with Dr. Sham. So we move on to our next session. So next session is about GLP-1 receptor agonist. They have really become the talk of the town in the past few years. They have given and they have added a new dimension in diabetes care. So to talk about GLP-1 receptor agonist, upstream treatment approach with GLP-1 receptor agonist, I invite Dr. Jasjeet Singh Vasir. Sir is Director, Division of Endocrinology at Medanta MedCity, and Sir has a keen interest in obesity management. So it will be interesting to hear from Sir. So over to Sir.
Thanks, Rujul. And so Dr. Sunil had very correctly pointed out the importance of obesity management, diabetes management, with a reflection on prevention of complications. So we take it a step further, a step up from what we routinely talk about is just glycemic control. So we're going upstream here now. And by upstream, we actually mean that we start intervening at a much earlier time so that we can optimize the benefits we can provide to our patients. So that's why it's titled as upstream approach with oral GLP-1 RAs to optimize outcomes. So traditionally, it's very clear. We understand why do we treat diabetes? It's no more a glucose-centric approach where we're just focused about controlling the blood glucose levels. We're talking about prevention of complications. And in that, the A, B, C, and O principle are sacrosanct, with A being optimal targets of A1C, B, optimal blood pressure, C, optimal lipid control, and O is obesity or weight management. So a multi-pronged approach is mandatory to ensure the best outcomes as far as controlling all of these factors and the outcomes of diabetes, that is the chronic complications of diabetes. So with this background in mind, in the next about 15-20 minutes, let's see where we stand right now as far as giving our patients or providing our patients with these possible benefits of prevention of complications. So this is my financial disclosure. We all know, understand, and experience the diabetes epidemic. Along with that, we have the obesity epidemic. These combined together is now termed as diabesity and becomes an important issue to be addressed together in our patients with diabetes. The most hard endpoint for any disease or any therapy is its impact on the quantity of life, which is all-cause mortality, how much it increases it, and when we talk about a drug, how much it decreases it. So presence of diabetes and obesity together, which is diabesity, has a seven-fold increase in the risk of all-cause mortality. This makes it very clear rather than saying obesity increases lipids or obesity predisposes to hypertension, lipid disorders, this, that. We've summed it together in putting it as the hardest endpoint in medicine, which is a loss of life or all-cause mortality. So that's the quantum of impact of diabetes and obesity when put together in diabesity. Now, a very peculiar thing about the reason why Asian Indians are predisposed more to diabetes, to obesity, to all non-communicable diseases is a very peculiar phenotype, which we call as the thin fat Indian. Very simply, same weight or the same BMI, white Caucasian and an Indian would have lesser muscle mass. That's very important. And more important than that, the Asian Indian houses greater amount of total body fat. And very peculiarly, all of that fat or a lot of that fat is centered around the central area, what we call as central obesity, increased waist circumference, or visceral adiposity. One of the most important pathophysiological defects causing increased occurrence of diabetes, its complications, and other non-communicable diseases in our country. So from this slide, we have a possible reason why diabetes and its possible some of the complications occur more in Asian Indians that directly provides us with a target is controlling that adiposity. So in this slide, I would like you to focus first So I'll just switch on my video and switch it off because I am walking in my room. So you actually won't be able to see me. Is this fine? So in this slide, let's focus on the left-hand side. We have this word adiposopathy. It has two parts, adipose and pathy. Now, adipose tissue is a naturally occurring tissue. It's an endocrine organ and which gives you comfort when you sit on the chair. Where excess of adipose tissue accumulates in the body, it becomes pathological, and that's the starting place for lot of or almost all of the non-communicable diseases, including lot of cancers. So excess adipose tissue becomes pathological, and that's where this word is coming. This spills out into the vital metabolic organs, including the liver, the muscle. The adipose tissue itself becomes very volatile, and it also spills off onto the pancreas, potentiating the two very important defects of causing type 2 diabetes, which is insulin resistance and a progressive beta cell failure, which manifests itself as diabetes. So we have a one-way traffic happening from here, involving all of these organs, leading to these pathophysiological defects, which finally manifests itself as diabetes. Now, along with this, in the previous slide, we saw the combination of adiposity and diabetes and its impact on outcomes, including all-cause mortality. So these two sum up the importance of addressing adiposity or obesity in patients with diabetes. Another known fact is that people with diabetes have a slightly lesser potential of losing weight than those with diabetes. Here in the green, we have people without diabetes, and compared to them, you see any of the randomized control trials, all the trials of drugs which help in weight loss. When you compare the non-diabetics and diabetics, there is a slightly lesser quantum of weight loss happening in patients with diabetes. Well, that's just a fact. And bringing us to the point, we need to combine lifestyle changes and not just focus on medications for weight loss to multiply the benefits, because there is a direct relationship of weight loss with the clinical benefits, as we'll see in the coming slides. Now, the human body is what we call perfection. Any attempt to lose weight over a period of time will trigger certain changes, physiological changes in the body, where when you start from here and reach somewhat like this by the journey of weight loss, it triggers multiple neurohormonal changes in the body, which would increase hunger. And very interestingly, this hunger or attraction for calorie dense food increases. So you will not just eat more, but you will prefer to eat calorie dense food. Secondly, and very importantly, an effect of weight loss which may stay permanently, that the resting energy expenditure, which forms a chunk of the energy expenditure through the 24 hours, decreases. So these two physiological changes with weight loss prevent progressive decline in the weight, and gradually there would be a increase in the weight. Now, this is a challenge. So whenever we talk about weight loss, there are two parts to that. The first part is losing weight, which is relatively easier. However, the maximum number of failures in the weight loss journey happen in the maintenance phase, where a lot of efforts multiplied. You keep on increasing the intensity of exercise, making the dietary regimens even stricter. The weight just keeps on coming back because of these physiological changes which we've enumerated here. So we need a solution for that. So whether you're following diet, doing exercise, combining both of them, or even if you've undergone bariatric surgery, weight regain keeps on happening. So there is a big question mark, or there was always a big question mark about the maintenance phase. We have done excellent work in making or guiding people lose weight, but the weight maintenance has always been a challenge. So let's see how the drugs come into the picture and help to address this part of it. So these are the current the therapy options available for weight loss in our country. I've already talked about them. Uh, the cornerstone of any intervention for weight loss and or diabetes is centered around therapeutic lifestyle changes, which is nutrition, fitness. We have pharmacotherapy, which is approved in India, including orlistat, liraglutide. Semaglutide 2.4 milligram is approved. It's an injectable form, but currently not available. And as far as diabetes and weight loss is concerned, the oral GLP-1 of semaglutide up to maximum dose of 14 milligram is available. Naltrexone, phentermine is not available in the country, and weight loss surgery in those who come into the preview of failure of lifestyle or have a very high BMI, multiple comorbidities, makes them candidates for bariatric surgery. The challenges with lifestyle, we all know. I don't need to read this slide. The problem is with continuation of lifestyles. If you were made to eat a specific type of diet over a long period of time, one, the weight loss will become static. You get bored, you lose motivation, and it breaks. So we need something in our dietary interventions, and we do it at our center in making the diet journey, the nutrition journey, the exercise journey an exciting one. Understanding the dynamics of weight loss, the weight plateaus, and the weight regain, ensuring that there is a continuity of efforts in the lifestyle over a long period of time, aided with other measures, including drugs, devices, and where required, bariatric surgery. So this is exactly where we stand. I talked about maximum successes happen here and maximum failures happen here. So if you were to do nothing, even with bariatric surgery, you would have a deeper weight loss. However, you see this regain. This is where loss of motivation, loss of efforts happens. Instituting pharmacotherapy will not just help in a prolonged reduction of weight, effective weight loss. However, it goes a long way in preventing the weight regain. And that's the next part of the armamentarium we have at this point of time to ensure their journey is a continuous one and the benefits are received with them by doing all these interventions together. The current therapy for diabetes which are available, which are have a weight loss potential, are the GLP-1 RAs, the SGLT2 inhibitors, metformin, off-label use for weight reduction. In the US, it's very commonly prescribed in patients who are non-diabetic. But again, as I say, it's off-label because the responsiveness to metformin is there is an extremely large heterogeneity. In clinical practice, in patients who have diabetes, about 5% of these patients have an extreme response to metformin in weight loss and or other effects or side effects. 10 to 15% would have a milder effect on weight. However, most of our patients, in excess of 85%, the drug is weight neutral. So when we talk about weight loss, top of the list would be a GLP-1 RA, SGLT2 inhibitors, and metformin is the crown king of diabetes treatment even right now. The actions of GLP-1 RAs won't go into the exact details of how it is acting, but in clinical practice, what is the patient going to come and tell us? Doctor साहब भूख कम लगती है, and the second part is satiety, पेट जल्दी भर जाता है. So the effects of these drugs are running through these neural pathways with these particular receptors are affected, leading to its clinical benefits. We have a lot of patients coming back to us saying that their specific liking for the things they used to love to eat has gone down majorly and it has turned into a distraction, that the very thought, sight or aroma of that particular food may feel them may make them feel very uncomfortable, and some of them end up vomiting with just the sight of that food. So that's the central action of GLP-1, including the oral semaglutide. SGLT2 inhibitors, we all know how they act. In an important aspect of weight loss, since we're talking about diabetes, important aspect of weight loss with SGLT2 inhibitors is that there is glycosuria which would persist. So 60 to 90 grams of glucose would go in the urine. So we would actually expect a progressive weight loss to happen in these patients. However, in clinical practice, we see a very slight reduction in weight and it plateaus, and at times it may increase a little bit. However, the expected or what we observed weight loss is much lesser, and the possible reason in either gender is an increase in the appetite. They just start consuming more calories, even though they're losing more calories in the urine, leading to a positive balance of energy, leading to weight gain. So based on this one very principle and a lot of other possible reasons of complementary actions, a combination of a GLP-1 and a SGLT2 inhibitor, wherever possible, would lead to multiplication of its benefits on glycemic control, on weight loss, on blood pressure, and the various organ protection that we all know about and talk about. So understanding all the past slides I presented about the relationship of obesity, diabetes, and the way obesity progresses onto not just diabetes, but multiple other complications, including the metabolic ones, the mechanical ones, the mental ones, and the monetary ones. It becomes very obvious that if we intervene right at the beginning, where it is not adiposopathy, it is not pathological, but just progressive increase in the adipose tissue, we all can definitely prevent a host of complications. And once diabetes has happened, we still gives us an opportunity of helping patients lose weight and preventing the downstream micro and macrovascular complications. And even here, if a complication happens, still weight reduction becomes important because it will lead to secondary prevention or decrease in the occurrence of events after a particular complications is happening. So all along this stream, weight loss is extremely important from the very beginning when a disease has not happened, to when a disease happens, to when the complications of a disease happen. In this entire thing, weight loss is very important. So in today's date, we all are adopting the upstream approach to reduce the burden of the complications of diabetes. And those who are not diabetic, we would be preventing a large chunk of them from becoming a diabetic. So in the past, I talked about the relationship of percentage weight loss and its impact on diabetes. Let's understand this, and it has a direct implication the way we talk about, we think about, and we advise about weight loss in all our patients. So this study very clearly showed that up to 5% weight loss, you're looking at prevention of diabetes. Very simple, 3 to 5% weight loss, you can prevent diabetes. So who would be these people? They would be the high risk people, those who have obesity, a family history of diabetes, impaired fasting glucose, impaired glucose tolerance, just a 3 to 5% weight loss. Upstream approach. Remember that word. Remember the 3 to 5% weight loss. Not just it leads to a reduction in the occurrence or prevalence of diabetes or incidence of diabetes. It has a direct benefit in A1C reduction, reduction in the fasting blood glucose, better glycemic control. However, once diabetes happens, so we're coming a little downstream. You need to lose at least 15% of weight to lead to remission of diabetes. So what is easier to do? Lose 3 to 5% and prevent diabetes. What is more difficult to do? Lose 15% of weight and remit diabetes. And the same principle applies for all the complications of diabetes. It's best done as early as possible. So early aggressive weight management. So it's no more early aggressive glycemic control. We've added another aspect to early aggressive therapy of weight reduction, and we have the tools available. Multiple other cardiovascular risk factors include blood pressures, lipids, and going much beyond that, the pharmacotherapy of obesity has opened a domain never explored earlier, providing our patients with an opportunity to prevent diseases, to prolong life, to increase longevity of our patients. So I will just summarize in the next 3 slides the benefit of oral semaglutide. The pioneer is the drug trial program. Very importantly, just look at these numbers: 8%, 8%, 8%, approximately 8%. So across the board in the pioneer program, the average A1C of these patients was not very high, especially when we compare the patients who come to us in the outpatient for the first time. Their average A1Cs would be in excess of this number. Despite this relatively low A1C, with the 14 milligram dose, see the quantum of A1C reduction. It averages to about 1.2 to 1.3. That clearly proves the efficacy of the drug, that with a relatively normal A1C, the 14 milligram dose could lead to a 1.5% reduction in A1C. The other thing coming out of this slide is, to get this particular benefit, we have to graduate or guide the patients to graduate from 7 milligram to 14 milligram for maximizing the benefits. And another principle which applies for any intervention for glycemic control: higher the starting A1C, greater is the A1C reduction. So somebody who comes with a much higher A1C in excess of 9, you would expect A1C reduction in excess of 2, 3, 4%, depending on their baseline A1Cs. Similar is the benefit for weight loss. Again, the same principle applying to maximize the weight loss to reach these kind of numbers up to 5 kilogram. Now, these are randomized control trials. In clinical practice, we all would agree about the fact that our patients are losing much, much more weight, and even at doses lower than the 14 milligram than in the pioneer trials. But this is more of clinical practice. But for sessions like this, we would restrict ourselves to this number of approximately 5 kgs weight loss over a short period of time, as small as 26 weeks. This adds on to the benefit of multiplying. So we are giving effective glycemic control, we're giving weight loss, multiplying their benefits on reduction of the future risk of complications. Compared to empagliflozin, this is like comparing apples and oranges. I would never do that, but the trials have been done, because unless you do a trial, you can't document how much more effective it is. It provides better glycemic control, greater weight loss. And in the past slide, when we talked about the expected and the observed weight loss with the SGLT2 inhibitors, I would not say we should compete these drugs. I would say complement by using both these drugs together to maximize the benefits to our patients. Because of its effects on the appetite, on glycemic control, it leads to a better reduction in the quantum of fat, reduction in the waist circumference, and the quality of weight. So whenever we talk about weight loss, we talk about fat loss and muscle building, and any and every intervention till recently led to fat loss. However, some amount of muscle loss did happen or does happen in our patients. With semaglutide, as we can see in this study, we're looking at a major reduction in the fat mass. However, the muscle mass does not seem to show much of a reduction. It's a reduction which we are very concerned about. But as per this trial data, there was just fat loss, which kind of preserved fat mass. So important has been the impact of the SGLT2 inhibitors and the GLP-1 RAs. Till recently, we were talking about cardiovascular risk reduction, renal risk, etc., to decide the kind of therapies. Now, with the advent, acceptance, and approval of these medications, as we see here on the right hand side, we have about 1/4 or 1/5 of the entire graph talking about the importance of weight management and the options available. With right at the top, if cost issue is taken off, with GLP-1 right being at the top when we talk about addressing diabetes with a single stop shop. So I end here just to briefly summarize. Understanding the India and the whole globe is experiencing an epidemic of diabetes. Presence of diabetes and obesity together multiplies its effect on the outcomes. Addressing obesity in all patients of diabetes is mandatory. It multiplies and increases the chances of reduction of the complications of diabetes. That's the core reason why we treat diabetes. And the upstream approach of early intervention leads to maximizing the benefits on the clinical effects we've talked about. So I thank all of you for your patient listening.
Yeah. Thank you, sir, for a very interesting session on diabetes management. So there is one query from the audience. One's audience attendee wants to ask that how do you foresee the role of GLP-1 receptor agonist, their use expanding to management of diseases other than that for diabetes?
No questions about that, and it's not just oral GLP-1 RAs. The injectable form, this is 2.4 milligram. There was a recent publication in obese people, non-diabetic. It led to a 20% reduction in the MACE outcomes, which is possibly the first study of its kind, which has proven weight reduction and cardiovascular benefits. So the future of these drugs is not just restricted to diabetes. It is going to be adopted and used by all specialties, to which the impact of obesity happens, which basically includes all specialties.
Oh, yes, definitely its use will also expand to other diseases other than that for diabetes like SGLT2 inhibitors. So I once again thank Dr. Jagjeet Vasir sir for his interesting session. So now we move on to the next session. So as we all know that diabetes is the leading cause of end-stage kidney disease. And in the past few years, many new treatment modalities have come up for the management of diabetic kidney disease. So to discuss about the management of diabetic kidney disease, I invite Dr. Sham Bansal sir. Sir is Senior Director and Head Department of Nephrology at Medanta, Gurugram. So over to sir.
Okay. So am I audible now?
Yes, sir, audible.
Okay. Thank God. Actually, I have another meeting sometime. So I hope my slides are visible.
Visible, sir.
Okay. So thank you once again, Rajul and Sunil, for inviting me for this session on diabetes. And I'm going to briefly discuss about management of kidney disease in diabetes, which is a topic given to me. So, as you all know that chronic kidney disease, this is one of the recent update which has shown that approximately 10% individual worldwide have some form of chronic kidney disease. Of course, most of them, they are in the early stages of the chronic kidney disease, but many of them are going to progress. And the chronic kidney disease has becoming the one of the more common causes of death, and it is going to take over as one of the top 10 leading causes of death in the near future. And in some of the countries, it is already one of the top 10 causes of death. And it puts a significant burden, especially in the low and middle income countries, because of the high cost of the treatment. So if we talk about India, in India, this is one of the study which is a Seek study, which is the screening and early evaluation of kidney disease in the community, and they found that about 17% of the adult Indian population had some form of CKD, mostly CKD stage uh, 1, 2, and 3, and approximately 10% had CKD stage 4 and 5, and which is, if we see by the size of the country like India, that is also a huge burden. In India, currently approximately 2 lakh patients on dialysis and approximately 5,000 dialysis centers across India. But the problem with the patient with CKD in India is that approximately half of the patient they are detected at stage 5, and most of the patient they are detected in less stages. Only approximately 5 to 6% of the patient they are detected in early stages. The early detection is very important, and then we can probably use a lot of new medicine to slow the progression of the disease. Diabetes, as you all know, is the most common cause of kidney disease, CKD, worldwide. This is a figure from the US sometime back. Approximately 45% of the patient had diabetes as a cause of kidney disease. In India, and diabetes and hypertension is the second most common cause of death. In India, this is a data from Indian CKD registry, which shows approximately 30% of the patient had diabetic nephropathy. But now we see in our practice that this number has gone up, and we find that approximately 40% of patients with chronic kidney disease have diabetes as their basic disease. What is the prevalence of diabetic kidney disease in type 1 diabetes? Approximately 30%, and type 2 diabetes, approximately 40% would have diabetic kidney disease. One of the things which I mentioned earlier, that despite high prevalence of CKD, the detection of the CKD usually late, and as compared to the statin eligible adult in USA or diabetes which has been diagnosed early, only 10% in the adult with CKD are diagnosed at stage 3 in most of the country. So the early detection is very important for the this thing. So coming to the risk factor for diabetic kidney disease, so there are various risk factors. Some of them are modifiable, so others are not, like demographic, older age, sex, and diabetes. The Indians are one of the population which are actually more predisposed for the diabetic kidney disease. If there's a family history of diabetes, there's a genetic kidney disease, then there are hyperglycemia, obesity, hypertension, and then of course there are other things like toxins and smoking and AKI. And these are the other risk factors for the susceptibility, initiation, and progression of kidney disease in patient with diabetes. The pathophysiology of kidney disease in diabetes is multifactorial, heterogeneous. In type 1 diabetes, it is usually chronic hyperglycemia and hyperfiltration. In type 2 diabetes, it's a heterogeneous disease. So there are other factors like hypertension, dyslipidemia, obesity, age-related nephron loss that also contribute significantly to the pathophysiology of diabetic kidney disease in type 2 diabetes. This is one of the diagram to show that this is a normal glomerulus with the podocyte foot processes. In diabetic kidney disease, there is a progressive loss of the podocyte foot process, and there is a effacement, or we say the podocyte effacement or the fusion of the foot processes. And the earliest changes included the thickening of the glomerular basement membrane and mesangial hypercellularity. These are some of the changes we see in the histopathology, starting from normal glomerulus to the thickening of GBM, mesangial hypercellularity, early nodular changes, classical Kimmel-Wilson lesions, and then there are some hyaline microaneurysm in the capillaries and the glomerular sclerosis. These are the classical changes which are seen in diabetic glomerulopathy. So I was discussing today in one of the Facebook with Dr. Sunil, and I was telling about this thing. The trajectory of diabetic kidney disease has changed recently with the advent of many new agents, and this is the classical phenotype in which we used to study that once the patient develop microalbuminuria, then macroalbuminuria, then there's a progressive loss of GFR, and the patient develop kidney failure over a period of 10 to 15 years once the patient develop microalbuminuria. But this is not the usual picture which is seen nowadays in all the patients with DKD. Some of the patient, if you start intervene early in the stage of microalbuminuria, they can even there will be regression of albuminuria, and these patients would not progress. One subset of the patient, especially those patients who had vascular disease, they can sometimes develop rapid decline in kidney function. The exact pathophysiology which is not known, and some patient with diabetic kidney disease, they would not have proteinuria, approximately 20 to 30%. This has been seen in multiple studies. So this is a multifactorial thing, and the prognosis can vary in different patients. So why there is so much difference in the trajectory or phenotype of the diabetic kidney disease? Because of the difference in the risk factor, lifestyle factor, demographic factor, clinical parameters, use of the drugs which can actually reverse if you use them in the early stages. There's an inflammation, then there is a histopathological finding. So it depends on various a lot of things. So this is not a uniform uh, in all the patients with kidney disease. And as you can see, we can from this class we can come to this class, and sometime uh, as the proteinuria is higher, the chances of the progression of the diabetic kidney disease increases. But then there is a reversal possibilities also. What can we do to slow or the progression or to treat these patients? So the one of the most important treatment always for all the patient with any chronic disease is the diet and exercise, and diabetes is no exception. Regular exercise will improve overall functional capacity. Let me tell you, the most common cause of death in patients with kidney disease, and especially in the diabetic kidney disease, is the cardiovascular diseases. So, if with exercise, if you are able to reduce your risk of the cardiovascular diseases, more than 50% patients die of the cardiovascular disease before even reaching to end stage kidney disease. So that's an important part of the treatment. Exercise, then diet, low salt, and then the potassium restriction, protein, which is in the, I would say, uh, depending on the status of patient, whether you need to very low protein or low protein or adequate protein, it will depend, but you should take a healthy diet. And smoking cessation is very important for the reduction in the cardiovascular and the kidney failure. So there are things which two type of approaches. One is the indirect approach where we target the risk factor, that is hyperglycemia, hypertension, hypervolemia, dyslipidemia, and another is the target renal pathology directly by slowing down the EGFR decline and reducing albuminuria, which we have newer agents. So apart from diet and so these are some of the important things which we need to control in patient with diabetic kidney disease. Control of hypertension, diabetes, protein restriction, weight reduction. Already Dr. Just discussed dyslipidemia and a specific agent. Actually, there's a lot of other things but we can't discuss everything for the time is limited. So, if we see, these are the various trials which have been done in patients with kidney disease, mostly in patient with diabetes. So, Initially, AC inhibitor and ARB were the only agent which were used to slow down the progression for approximately 15 years, when then there come various other agents like SGLT2 inhibitor, LP1 receptor antagonist, and then selective MRA mineralocortical receptor antagonist, that is the fendanon. So hypertension control is the focus in patient with diabetic kidney disease, and the other one is AC inhibitor and ARB. As you can see that hypertension prevalence is very high in patient with kidney disease, especially diabetic kidney disease. More than 90% of the patient in stage 5 would have hypertension. And in the diabetes kidney disease, even the earlier stage 3 or 4, the prevalence of hypertension is quite high. And hypertension causes both a progression of kidney disease, and it is a complication of the CKD, and it is associated with the poor cardiovascular outcome and rapid loss of kidney function. So if the hypertension is not controlled well, many of the patients, they can lose their kidney function very quickly, and from the stage 3 to stage 5, it will not take much time to reach there. As you can see in this graph, that this is the untreated hypertension. The blood pressure is 170, 180, and this is the hypertension with the normal, I would say 140, 90, which was the previous target. And this is the optimal control. And the loss of GFR difference is quite significant with this control of the hypertension. The choice of agent is AC inhibitors and ARBs, and they actually act on multiple targets. I'll skip that part. Why these agents are drug of choice? Because there have been multiple studies in the 90s and early 2000, which have shown that these agents significantly reduces the doubling of the creatinine and progression to end-stage kidney disease or death by approximately 20% as compared with placebo or compared with other drugs also. Both in type 1 diabetes, this was the initial study, and type 2 diabetes, these are the renal and IDNT study, which were conducted in patients with type 2 diabetes. And as I earlier mentioned, there is 15 to 20% reduction in the risk of the progression of the kidney disease in patients with diabetes with use of these agents. But there is a fear of using these agents because sometimes these agents, because of their hemodynamic effect, and can lead to increase in creatinine. But we should not be worried about that. You should monitor the kidney function and potassium once you start these agents. So if the rise of the creatinine is less than 25%, one should continue these agents and monitor. If the rise is more than 25%, then you can stop and then evaluate whether this patient had renal artery stenosis or some other factor like volume depletion or something else which is going on simultaneously, which cause this increase in creatinine. There's no absolute cutoff of the GFR, and these agents act better when you have low salt diet. And some of these patients, because diabetic kidney disease, there's a very high chances of the fluid overload, and then some of these patients would require the diuretic even in the early stages. Volume depletion should be avoided, and combination of the AC inhibitor ARB should be avoided because risk of the adverse effect hyperkalemia increases in these patients. Obviously, it is important to understand that blood pressure control is most of these patients would require addition of one or two more drugs apart from the vitamin B, and the target, which is the after the sprint trial, is as normal as possible, means 120/80, but then it is not for everyone. Some of the patients who are vulnerable, who have limited life expectancy, or those on the dialysis may require a higher target. Another important part of the management of DKD is the lipid management, and this is a study which has shown that this use of the statin does not improve the renal outcome. So this has been seen in many studies that renal outcome does not improve, but there is a improvement in the risk of the cardiovascular events and the mortality in patients with CKD, especially diabetes. So statin in any case it should be used in patient with diabetes, and in the CKD patient, it's important to use in all these patients unless there is a contraindication. Uh, this is an algorithm that how should we use these patients. So in patient, this is even those patients who do not have diabetes. In the diabetes, there is no confusion that one should use statin in all these patients with diabetic kidney disease. Briefly about sugar management. You are all endocrinologists and physicians who sees more diabetes patients than me. But as you understand, once patient develop kidney disease because of diabetes, there's a more chances of the hypoglycemia. And so because of the various factors, because of the metabolism of insulin by the kidney, which reduces, and the kidney contribute to the gluconeogenesis, which also comes down. The half-life of which is increased, insulin half-life is prolonged, and food absorption is erratic in patient with advanced kidney disease. And then there are factors like coexisting autonomic neuropathy, secondary or tertiary hyperthyroidism, metabolic acidosis. All these can worsen insulin resistance. And if the patient is on CAPD, then he receives this fluid, which is dextrose rich, which can again impair the glucose control. You know that these are the trials DCCT, and I will not go into the detail of these trial leukopedia, which have shown that the glucose control in the initial provides a long-term benefit in the microvascular complication, and the diabetic kidney disease is one of those complications. But very strict control of the sugars in patients who have diabetic kidney disease does not show much benefit, and so the target of diabetes control should be individualized in this patient depending on the age of the patient, other complication, comorbidities, and all that. So this is an algorithm which shows that we should individualize the target. The patients who are early stages, you can target on the lower side, who do not have macrovascular complication or comorbidities or good life expectancy, or there's a hypoglycemia awareness. All these patients you can be slightly strict target, but those patients lacking their target should be 7 to 8%, and they should be educated about the hypoglycemia and the drugs. SGLT2 inhibitors, as you all know, is an important advancement in the management of diabetic kidney disease. I'll not go into the mechanism, but basically they act synergistically with AC inhibitors, and both these agents basically reduce the hyperfiltration. AC inhibitor, they cause the dilatation of the efferent arteriole, and AR with this will cause the uh, uh, constriction of the efferent arteriole, thereby reducing the hyperfiltration and subsequently reducing the progression of the kidney disease. This is the DAPA-CKD trial, which has shown that patient with the diabetes and kidney disease, when dapagliflozin was given in those patients as compared to placebo, there was significant improvement in the endpoint reduction, up to 40% reduction in the kidney-related side effect, kidney-related effect, and 30% reduction in the mortality. And there are various other drugs and the other studies, which I'll skip at the moment. And the SGLT2 inhibitors are very important part of the treatment in patient with diabetic kidney disease. One should add these agents, especially in the patient with proteinuria, and if other agent is used, and the dose could be reduced if the sugars are well controlled, or if the sugars are not reduced, sugars are not adequately control, then you can simply add this SGLT2 inhibitors in these patients. Metformin is a very important part, and it's now more and more evident that one should continue metformin even at the GFR of till 30, but you should reduce the dose. But less than 30, it is still not recommended. But SGLT2 inhibitors you can continue till the patient reaches to the stage of dialysis. Nowadays, there have been being studied whether you can even continue SGLT2 inhibitor in patients on dialysis also because of their cardioprotective effects. So, there's a comprehensive studies. You would use various agents in patient with diabetic kidney disease. So all this exercise, nutrition, smoking cessation, lipid management, BP control, RAS blocker, SGLT2 inhibitors, these all should be used in patient with diabetes. I would then come to our last agent, which is the uh, mineralocorticoid receptor antagonist, and briefly about it. Basically, even after using losartan, reduce the risk by 16 to 20%, and further reduction in the risk by SGLT2 inhibitors, another 15-20% reduction. But there is a residual risk which is not taken care of. And there are three pathways, as I discussed, for the CKD progression patient with diabetes 2. Hemodynamic, that is the blood pressure; intraglomerular pressure; metabolic, that is the glycemic; and the third pathway is inflammation and fibrosis, and which is still, if we see, was not taken care well. And this Fendranon is a newly developed mineralocorticoid receptor antagonist, which is a non-steroidal, which has both anti-inflammatory and anti-fibrotic property in preclinical models. And as I mentioned, and this is a unique structure, and there's a very high selective and potent interaction with mineralocorticoid receptor and causes regulation of the gene expression. So this is the study which has been done, Fidelco TKD study. Patient who had moderate to severe proteinuria, more than 18 years of age, already on AC inhibitor and ARB, but their serum potassium less than 4.8, and who had diabetic retinopathy with also. The patient who had very high sugar level, other kidney disease, uncontrolled hypertension, or heart failure with NYHA class 2 to 4 was excluded. And as you can see, the Indranon versus placebo in all stages of the CKD till GFR less than 25. And this is the median level of proteinuria in these patients. Most of the patients, they had proteinuria more than 300 milligram. And there was 31% reduction in USCR between baseline at 4 months between placebo and Fendranon. And the serum potassium was slightly higher, but it is not very significantly different. And most of the patients, they were able to continue their treatment. And there is a significant reduction in the primary outcome in this patient by decrease in the renal outcome improvement by 18%, and cardiovascular outcome, which is the secondary endpoint, by 14% in these patients. So this is a new addition in the treatment of diabetic kidney disease. A slide about the protein restriction. Protein restriction is usually advised too much in patient with chronic kidney disease. In Indian patient, if we see specifically, that vegetarian diet usually does not have so much of the protein. Most of the patients are still taking a low protein diet. Even the normal adult would be taking protein which is restricted. And many of the patients, they develop malnutrition. There's a little evidence to suggest that lowering protein intake less than 0.8 is beneficial, and it can lead to the malnutrition also. So one should be very cautious when prescribing the protein restriction, especially in patients with diabetes, kidney disease. And one important aspect of medication in patient with diabetes, diabetic kidney disease, because these patients are high risk of adverse effect because of the medicines. Many drugs are renally eliminated, so it's important that you should adjust the doses of the drugs when prescribing these drugs. One should always see that NSAID or other nephrotoxic drugs should be avoided in the beyond stage 3, 4, and dual RS blockers should not be used. Dose adjustment is required, and then you need to be careful about using contrast media, CT contrast media, and gadolinium containing MRI contrast media if EGFR is less than 30. But then, whenever necessary, one should use the contrast media. And it's very important to understand when to refer these patients to the nephrologist. Because sometimes some of these kidney disease, they are reversible. So if there's acute kidney injury or sudden reduction in GFR, when the patient at GFR less than 30, he would most likely need a preparation for RRT. In these patients, if the proteinuria is very high, sometimes these patients can have some other disease, superimposed on diabetes like the glomerular diseases, membranous nephropathy, minimal change disease. If there's sudden proteinuria, very heavy proteinuria, one should take a consultation for nephrologist. If there's a progression is atypical, if urine sediment is active, there are RBCs in the urine. Usually, there are no RBCs in the urine in patient with diabetic kidney disease, hypertension, which is refractory to the treatment, and the potassium is very high, nephrologic cases, hereditary kidney disease. These are some of the indication when one should always take a referral from a nephrologist. So, if we make a small changes, so if you see this is a 25-year-old male, if you slow down, this is the usual progression. If his GFR is falling 5 ml per minute per year, in he will reach to end stage kidney disease in next 20 years. But if you can reduce the progression and slow the progression, that it will make a lot of difference, and he can have many more years of his kidney, natural normal kidney functioning, rather than requiring dialysis or transplant. Thank you very much for your patient hearing.
Yeah, thank you, sir, for giving us the latest insights about diabetic kidney disease management. There are two queries from Dr. Pushpender. He wants to ask whether urine routine microscopy is a reliable test for assessment of albuminuria and diabetic kidney disease.
No, so urine routine is not very sensitive test. It usually detect proteinuria, which is you should have at least usually 50 to 100 milligram of TL of proteinuria. So it's better to do the urine albumin creatinine ratio to identify our urine microalbumin. And there's nothing like microalbumin. This is a normal albumin in the lesser quantity. So urine albumin creatinine ratio should be done in patient with diabetes 5 years in type 1 diabetes. But in type 2 diabetes, the diagnosis, because some of these patients may have diabetes going on for some period of time before they are detected. So urine albumin creatinine ratio, not urine routine.
Yes,
Sir, is spot urine albumin creatinine ratio are 24-hour? Is there any
Spot,
difference?
a spot. No, a spot is sufficient. 24 hours is cumbersome, and this has been
Yeah.
validated. If you take the spot urine albumin creatinine ratio, that is sufficient and good enough to diagnose for the screening and even for the follow-up purpose. We hardly do 24-hour routine urine protein nowadays, except if there's a discrepancy. If we see that the use of this, there could be some other low molecular weight protein, some non-albumin protein because of the interstitial kidney diseases, then we do 24-hour protein or like.
So
the,
there's
yes.
one another question is there any specific indication for finrenone or some pointers that we can see that this is the candidate for this?
No, the Finradon now, because see the study which was done for the Finradon was in patients who were on AC inhibitor and ARB, but in that study only 4% of the patients they were on SGLT2 inhibitor. SGLT2 inhibitor. So SGLT2 inhibitor, because there are a lot of data, and they are used as the second agent after the AC inhibitor and ARP. So if the patient tolerates, so nowadays we are giving it to many patients who have this potassium within the less than 4.8 or 5, and there is further reduction in proteinuria. So if patient can tolerate, unfortunately, most of these patients, our patient, we cannot use because patient comes to us in the advanced stage. But you can use in many of the your patient if the GFR is not so low, if the hyperkalemia is not a problem.
So the other queries, what is the upper limit of serum potassium at which one should be cautious about initiating or titrating ACE inhibitors or ARBs in DKD patients?
Yeah, so more than 5, probably you should not start. So many patients who come with the potassium of 5 or more, they should be told about the dietary restriction, how to control their potassium. And some of the patients with type 2 diabetes, they have type 4 RTA. So because of that, there is impaired excretion of potassium. So some of these patients you can't give AC inhibitor, ARV. So one should monitor, and if the potassium after the dietary restriction is within the normal range, then one can start and monitor the potassium as required initially after 2 weeks, and then if the patient is okay, then but if we continue AC inhibitor ARV even when the potassium is up to 5.5 or this thing, if patient is clinically doing well, but obviously I will not initiate if the potassium is already more than 5.
Yeah. So there's one final query. So is there a difference in the clinical course between albuminuric and non-albuminuric forms of diabetic kidney disease?
Yeah, so non-alcoholic form of the diabetic kidney disease, you would not have much edema, would not have much hypoalbuminemia, and the progression is also because there's a more of a vascular disease. So there are and normally there's a more of the glomerular involvement. That is why there's a proteinuria. In non-albuminuric disease, more of vascular disease. So many of these patients would have simultaneous cardiac involvement, coronary artery disease, peripheral vascular disease. These are some of the features in these patients. And if you do kidney biopsy, you will find more vascular changes, arteriosclerosis, rather than the glomerular changes in these patients.
Thank you, sir. So I once again thank sir for his insightful discussion about diabetic kidney disease. So now we move on.
Thank you. Thank you very much.
Thank you, sir. So now we move on to the last session of today's update. So the last talk is about osteoporosis, which is a neglected and less often discussed chronic metabolic disorder. So to discuss about the treatment options in osteoporosis, I invite Dr. Parjeet Kaur ma'am. Ma'am is Associate Director, Division of Endocrinology at Medanta, Gurugram. So I invite ma'am.
Thank you, Dr. Rujul, for the kind introduction, and very good evening to all. I'll just share my slides. So as Dr. Rujul rightly said, this osteoporosis is often neglected, and this is completely a different topic of discussion in today's series. But at the same time, it's important to understand that bone health is equally important as kidney health, heart health, liver health, and especially in people with diabetes, because diabetes people are prone to develop osteoporosis. Type 2 diabetes people are prone to get increased fractures, and there are enough data to support that. So today, my focus of talk will be mainly on the newer and emerging therapies in osteoporosis. But briefly, I'll discuss about the available and current therapies, the mechanism of pathophysiology of osteoporosis, and focus will be on the one molecule, denosumab, today in the treatment of osteoporosis. So this is a definition of osteoporosis. It's defined as a skeletal disorder characterized by compromised bone strength predisposing a person to an increased risk of fracture. So why we are worried about osteoporosis? Because there is increased risk of fracture by even a trivial trauma, just by a fall. And once a fracture is there, the quality of life goes down dramatically. And one fracture increases the risk of subsequent fractures and subsequent mortality as well. And therefore, it's important that we do recognize this problem of osteoporosis in a timely manner and take steps to prevent it also, as well as treat it. This table shows the WHO working group definition of osteoporosis, which defines osteoporosis on the basis of DEXA scan, which is a bone density scan which measures the bone density here, which is defines normal bone health as T-score between +1 to -1, osteopenia between -1 to -2.5, osteoporosis less than or equal to -2.5 here. And it also defines osteoporosis as T-score of less than or equal to -2.5 with one or more osteoporotic fracture. Then this becomes severe osteoporosis. This definition is important to identify people who have osteoporosis, but we also have other criteria, which I'll just discuss in the subsequent slides. So pathophysiology of osteoporosis, there are multiple etiological factors, the multiple mechanisms involved, but this figure broadly tells you what exactly is osteoporosis. So in the left side, you have a normal bone here, which you can say we have thick bony plates here, very good connectivity in between the bones. But what happens in osteoporosis on the right side, if you see, the bony plates become thin and the connections are lost. So this kind of bone, when it becomes the trabecular material, when it's get depleted, this is called osteoporosis. This slide basically summarizes the mechanism of action of various drugs available. Also, it gives the insight into the pathophysiology of osteoporosis. So this slide basically is depicting the bone remodeling cycle and the medications which are available for the treatment of osteoporosis. So the bone remodeling cycle can actually be divided into 6 phases. There is a resting phase, followed by an activation phase, then a resorption phase, then a reversal process start. When the bone resorption happens, a reversal start that the bone starts forming, which is called formation phase. Finally, the mineralization phase when the whole bone is formed, and then again the resting phase. Now, if you look at carefully here we can see denosumab, where is it is exactly acting is, it's acting at this level where it's kind of acting as osteoprotoglin. So OPG is a molecule which binds to the rank ligands and prevents the rank ligands to bind to the rank receptor and prevents the activation of osteoclast. So osteoclasts are the one which are causing the bone resorption. So ultimate resorption. So therefore, denosumab action is mainly prevention of the bone resorption by inhibiting the activation of osteoclasts. So basically, it's binding to the rank ligands here, so that rank ligands cannot bind to the rank for the activation of the osteoclast. In the resorption phase, we have bisphosphonates. Bisphosphonates are most commonly used drugs in osteoporosis. What these agents do, they bind to the basically bone mineral here. They just get bind to the bone mineral. So where there is a site for binding of osteoclast, they occupy those sites. So by binding to those sites, osteoclasts cannot bind, and therefore they are not able to resorb the bone. This is then their main mechanism of action. These are the anti-resorptive agents. And then we have another class of drugs here called odanacatab, which basically acts as cathepsin K inhibitor. So what is cathepsin K? Is an enzyme which dissolves the collagen. It breaks down the collagen. So by inhibition of this enzyme, this is how this molecule acts. And similarly, another molecule, saracatinib, which acts on CSRC molecule, thereby inhibiting again the activation of the osteoclast. On the left-hand side, if you see in the formation phase, we have various other agents acting upon. We have SERMs here, which are mainly acting upon the osteoblast to basically inhibit the production of various molecules which activates the osteoclast. Then we have romosumab. Romosumab here acts mainly by binding to sclerostin. So sclerostin is a molecule which mainly inhibits the Wnt signaling in osteoblasts. So by inhibiting this molecule, it subsequently prevents the inhibition of osteoblasts. It's kind of predominantly action is then the anabolic here of romosozumab. Then we have PTHRP and PTH, which mainly acts to on the osteoblast, increase the formation of osteoblasts as an anabolic agent. And we have strontium also, which is not much in use. And then we have a mineralization phase. So this is mainly summarizing the mechanism of action of the various agents, but our focus will be here today on denosumab. So yes, just as I mentioned, we have this WHO working group definition based upon the BMD here, how we define, but we should not always rely upon BMD for diagnosis of osteoporosis. We should also look at the clinical criteria. For example, if the person has a history of a fracture in the past, especially the fragility fracture by trivial trauma, it proves that the person has osteoporosis, whether or not DEXA scan is showing or not. So that is important to know, important to obtain a history of fracture in the past. And then we have criteria FRAC score, which is kind of a score which is developed by putting in various variables, like we put in the BMD score there, and then we put in other risk factors there, whether the patient has taken steroids in the past or not, another age, other criteria, where it basically gives you a 10-year risk of hip fracture or a 20 hip fracture. And if this FRAX is projecting that 10-year risk is more than 3% for hip fracture or more than 20% for major osteoporotic related fracture, then you call that person as having increased risk of fracture, which means that means you need to treat that patient. So in a clinic setting, it's important first that you go by the clinical criteria first. So you will suspect osteoporosis, especially in a postmenopausal female who also has other risk factors, and go with the DEXA scan first and obtain certain histories, including, very important is the past history of fracture, family history of fracture, age, BMI, these factors, and then you calculate the FRAC score as well to determine the risk of fracture. So this is the prevalence in global Indian both. This slide shows that in Western, almost 30% of all postmenopausal women have osteoporosis, and around 40% of these women who have osteoporosis, and in fact 15 to 30% of men also, will sustain one or more fragility fracture within their remaining lifetime. 1 in 3 women over the age of 50 will experience osteoporotic fracture. That's a huge number. And 1 in 5 men as well will experience. And they have Indian data which show that 20% of around 230 million Indian women over the age of 50 have osteoporosis, and the prevalence in the various groups reported ranges from 8 to 60%. So numbers are huge here, and osteoporosis, this is, I would say, still a tip of the iceberg. I'm sure the numbers are much more than, and it's a huge burden which is being totally neglected. So we have to be very vigilant in picking up this problem and treating it timely. So management involves non-pharmacological therapy, surgical procedures, nutritional, pharmacological. Non-pharmacological therapy for osteoporosis, this will be mainly, of course, for the prevention, but even if person who has osteoporosis is very important, because what we are preventing is the fracture. So if we can prevent the fall, we will definitely prevent the fracture. So we need to focus upon the weight-bearing exercise. Weight-bearing exercise means anything like walking, is the best actually weight-bearing exercise, that you're putting weight on the legs, which builds up the muscles and puts strain on the bones to increase the bone density. Fall prevention is very important, that any person who has osteoporosis, a proper fall prevention guidelines should be given, how to prevent fall at home, outside. Avoidance of tobacco use, yes, because smoking is one of the risk factor for osteoporosis and subsequent fracture, and limiting the alcohol consumption. Calcium and vitamin D play an important role, although alone they won't be sufficient enough for the prevention. But yes, if we are giving a good amount of calcium in postmenopausal females, which can be to the tune of 500 to 800 milligram a day, and also vitamin D, which can be from 800 units to 1000 units a day, then it will be good at least to prevent osteoporosis. But those people who have at very high risk of osteoporosis or fracture, this alone won't be sufficient. So these are the current therapies available, and there are some of listed are the emerging therapies. Bisphosphonates are the most commonly used drugs in the treatment of osteoporosis, in which we have alendronate, resedronate, and zoledronic acid. Zoledronic acid is now more frequently used as compared to the oral agents because of the ease and given yearly basis. Then we have hormonal therapy. Hormonal therapy is mostly restricted to those postmenopausal female who have just entered the menopause or who are just perimenopausal, or maybe they're just in that window of opportunity period within 5 years of postmenopause where they are experiencing the menopausal symptoms also. Thereby giving the hormone therapy, we are kind of preventing the osteoporosis as well. Rank ligand inhibitor denosumab, anabolic agents teriparatide and recombinant or teriparatide and or what we also call as recombinant PTH, and the other agents like anti-sclerostin antibodies, romosumab, abaloparatide, and stem cell therapies. So briefly, one slide over bisphosphonates. As I just mentioned, how they act. Basically, they induce the apoptosis of the osteoclast, slow down the accelerated bone resorption because they bind to the site bone mineral area and are taken up by the mature osteoclast, and then these osteoclasts are gets deactivated, disabled, and then they're not able to resorb the bone, called the bone resorption. It has been shown in the various studies they cause an increase in the lumbar spine BMD from 4 to 9%. They reduce the risk of new vertebral fracture from 41% to 62% over 3 years for oral bisphosphonate, 70% for IV zoledronic acid over 3 years. Adverse effects with oral are much more, where patients can experience a lot of esophageal and gastric irritation. Limitation comes up when the patient develops CKDs, when we're not able to give these agents. With IV zoledronic acid, we face a lot of problems, sometimes acute phase reactions. Patients can develop fever, a sepsis-like syndrome also, and then the fear of osteonecrosis of jaw and atypical femoral fracture is always there. And very importantly, oral therapy non-adherence is very, very common, and these patients are not able to continue with the oral therapy for a long time. Estrogen, I just mentioned, will be mostly suitable for those very menopausal and very short menopausal lady who are also experiencing the menopausal symptoms. Similarly, raloxifene also will come into that category only. Strontium, I'm not going to be not in much in use. Teriparatide is one powerful and osteoporosis agent and treatment therapy where it's mainly an anabolic agent. Where it stimulates the osteoblast and increasing the bone remodeling. So this is one wonderful agent which helps in making the bones strong, for bone forming agent. And whenever we think of patient where we want to specially work upon the lumbar spine density, then this agent works very well. We prefer this agent first, and then subsequently we add on other therapies. So it has been indicated, this teriparatide is indicated in the postmenopausal women and also in men at increased risk of fracture. Also, it is approved for treatment of osteoporosis with sustained systemic glucocorticoid therapy in both men and women who are at increased risk of fracture. The dose is given usually 20 microgram once daily, administered subcutaneously into thigh or abdomen. And again, the use is been limited to 2 years. So after that, we anyways need to stop this agent. So efficacy of teriparatide, various studies have shown that it causes a mean BMD increase of around 9% at lumbar spine, relative risk reduction of new vertebral fracture by 65%, relative risk reduction of non-vertebral fracture by 53%. So this is a very strong agent. But then there are certain contraindications. We need to be careful, like patients has Paget's disease, we cannot give. Previous exposure to radiation, cannot give due to the fear of osteosarcoma. Other common adverse effects which patients might observe while taking teriparatide are injection site reactions. They can develop body pains, body aches for some time. Many patients actually continue to experience such side effects, so we need to handle that. And there are the nausea, limb pain, headache, and dizziness. Now coming on to the denosumab. So for that, let's understand what is rank ligand. It's a physiological stimulator of osteoclastic maturation and bone formation. So what happens is when the rank ligand expressing cells are there, it binds to them, then it kind of activates these osteoclasts and make them in a mature osteoclast. So alteration of this rank ligand to osteoproteogen ratios. Osteoproteogens is the one which basically blocks the rank ligand. So when this ratio alters, that means rank ligand is more than the osteoprotein, that is the main underlying reason for even the postmenopausal osteoporosis. So denosumab is basically a monoclonal antibody which acts against this rank ligand and acts by preventing the rank ligand from interacting with rank, its receptor, on the osteoclastic precursor cells. So on these osteoclastic precursor cells, when it binds to this denosumab here, it binds to this rank ligand, then it is not able to activate these cells to form the fully blown osteoclast. It is approved, and it is the approved indications. Even in India, it is approved. So it's for treatment of postmenopausal women with osteoporosis at high risk of fracture, treatment to increase the bone mass in men with osteoporosis, glucocorticoid-induced osteoporosis also it is approved, and the dose is 60 milligrams subcutaneously. It is given once in 6 months. So various guidelines recommend denosumab as in one of the, in fact, ACE recommends denosumab as one of the first-line treatment osteoporosis. Well, most of the time we tend to individualize the therapy as we do in the patient with type 2 diabetes. It's not that one agent has to be given as first line and secondly. So it's not the rule that all the patients should be started on bisphosphonates first and then gradually shift. If failed, then shift to teriparatide. If failed, then shift to denosumab. So many times we do consider giving teriparatide as first line. Many times there are indications where we give denosumab as first line. So again, the indications here are always individualized, but can be used as first line as well. And the various guidelines endorse that any patients who are at high risk of fractures, Canadian guidelines says who are difficult in taking oral medications, for example, they can again be used as first line therapy in those cases. So we have enough clinical trials, and this FREEDOM trial was one of the largest trial in terms of demonstrating efficacy of denosumab. It was a multinational randomized double-blind placebo-controlled trial in postmenopausal osteoporosis, where denosumab led to significant reduction in both vertebral and non-vertebral fractures compared to placebo after 3 years, where you can see in vertebral fracture, there was 68% relative risk reduction, hip fracture, 40% relative risk reduction, non-vertebral, which was the composite endpoint, was 20% relative risk reduction in the fractures. So again, the same thing, the primary endpoint was a new vertebral fracture with a significant difference as compared to placebo, and it very less number of people on denosumab developed fractures, and the secondary endpoints were non-vertebral fractures, hip fractures. So where everywhere denosumab led to significant benefits in all the primary and the secondary endpoints. Now, when we look at the subgroups in the terms of by dividing the patients depend for the risk of osteoporosis according to the age or according to the femoral neck BMD score or a combined, even in the patients who are higher risk or lower risk, wherever they are acting equally. Denosumab gave equal results even in patients who are at very high risk of fractures or low risk of fractures. Denosumab led to the reduction of incidence of fractures in all these various subgroups. So regardless of the age and severity of osteoporosis, denosumab works. And this slide shows a change in BMD over time, very dramatic increase with the use of denosumab, and continues to increase. This is over a period of 3 years. When denosumab given, there was a tremendous rise in the BMD of lumbar spine, as well as total hip, more so in lumbar spine, as compared to placebo, where there was no change. So it did lead to significant and consistent improvement of BMD in 3 years. When we talk about safety, over 3 years of the FREEDOM study, as compared to the placebo, there was no significant difference in terms of the adverse effects. But one difference was in terms of eczema, which was found a little bit more on the denosumab group as compared to the placebo, but no major adverse effect was seen with the use of denosumab. Coming to the bone quality, but what we are interested is not just the BMD rise, but what about the bone quality? Is it really improving the bone quality or not? So what was seen in this study as compared to the alendronate, where it was mainly acting in the trabecular bone. So alendronate helped in preserving the trabecular bone, whereas denosumab also did so. But when we come to the cortical bone, the denosumab had very good action that it also increased the cortical bone density. So even at the cortical bone, denosumab increases the density, which was different from the alendronate, which was not able to do. So trabecular bone density increase was equal to the cortical, which means that it is helping in maintaining and improving the bone quality as well. A similar thing that the cortical porosity, which was shown, was very much improved. It reduced the cortical porosity, denosumab, in the proximal femoral shaft. Now, this is the Freedom Extension study, again, where they continued this treatment. One was the initial 3 years, and this treatment was continued over a period of 10 years. And what was seen that even in the extension study, here where the denosumab was continued, and this is the study in which it's a crossover. People who were not taking initially denosumab or were on placebo were given denosumab later. There was a consistent reduction of risk of vertebral fracture over 10 years. So it continued to work. Sustainability was there with the use of denosumab. What about the new hip fractures again? Again, with the new hip fractures, there was significant reduction with the continued use of the denosumab. There was a consistent reduction in the risk of hip fractures, both when the patients continued using denosumab or they continued, or they were crossed over and started on denosumab. Changes in the BMD again. BMD led to this denosumab led to continued increase in BMD. So once started, placebo was initially given, but then the patient were given on the long-term denosumab, or patients who were given placebo initially and switched to denosumab. Both of these groups showed a continued increase in the lumbar spine as well as total hip BMD over a period of 10 years. And what about the safety over a period of 10 years? Again, no significant safety issues were identified. Adverse effects were comparable between the denosumab group and the placebo group. So that was found to be very safe over a period of 10 years as well. Denosumab in impaired renal function is a very good action. I would say that whenever we see a patient with CKD, we always struggle to, even if it's a diabetes medication or whatever, we think what to give now. But denosumab is one agent which can be given even in patients who have a impaired renal function, because in this post hoc analysis of Freedom study, 73 women had eGFR of even 15 to 29 ml per minute. And many of these ladies had grade 2, grade 3 of the CKD. So fracture risk reduction was seen even in this group of population, and changes in BMD did not differ, and it could be safely used in this group as well. So it can be administered to patients with renal impairment without the need to dose adjustment. This is the beauty of this molecule, that we can easily use it even in the patients who have impaired renal function. In fact, we have used this molecule in patients who have hypercalcemia and CKD, where we are not able to control the give zoledronic acid because of the CKD. We are able to give this agent to control the hypercalcemia also. So this can be safely used in patients who have impaired renal function. Coming on to the various other agents which have been recently approved and emerged. Abaloparatide is basically a human parathyroid hormone related peptide. It's a selective parathyroid hormone type 1 receptor agonist. So it's mainly anabolic activity in osteoblast. And abaloparatide is FDA approved to be used in osteoporosis in postmenopausal women at high risk of fracture. This is used in the dose of 80 microgram once daily. And efficacy is that it results in 3.7 to 3.4 increase in the total BMD, increase in hip, femoral, necks respectively. There can be some side effects. Romosumab is a humanized monoclonal antibody which binds to inhibits the sclerostin. As I said, sclerostin is a regulatory factor in the bone metabolism, acting on the Wnt signaling pathway. This is an inhibitor of the Wnt signals. By inhibiting this, we are kind of preventing the deactivation, what we can, so preserving the osteoblasts here. So its main action is again the bone formation. It's kind of acts as a anabolic agent. And there are many studies available on romosumab as well. So it increases BMD in both lumbar spine and total hip, both trabecular and cortical bone, and leading to increase in the bone strength and reduced risk of fracture. It's given as a once-month subcutaneous injection for 12 months. Recommended dose is 210 milligram. The side effects are joint pains and headaches, which can happen with the use of this injection. Stem cell therapies and all are novel targets under experiment. This therapy is not in the, it's still in the animal experimentation stage. So to summarize, this table shows the currently available agents which are in use and where all it can be used, their dosages, how they're administered, and there are three conditions which we want to use: the postmenopausal osteoporosis, glucocorticoid osteoporosis, induced osteoporosis, or osteoporosis in men. And as you can see here, if you the last here, denosumab, it is yes everywhere. That can be used in postmenopausal osteoporosis as well, glucocorticoid induced osteoporosis, even in osteoporosis in men. It has shown good efficacy, and it's been approved to be used in any of these three categories. So summarize, in the treatment of osteoporosis, bisphosphonates combined with bone nutrients are the first line treatments. Again, I will emphasize upon this fact that we need to individualize a person who is coming to you, a lady who is coming to you with a severe osteoporosis, has already suffered a fragility fracture. Maybe bisphosphonates are not the first choice. We would go ahead with anabolic agents, teriparatide. More important, we go ahead with the combination therapy. So now there is a concept of combination therapies, sequential therapies. We are preferring more of a combination of a teriparatide and denosumab in the early phase to give a very good bone density, and then continue with denosumab later on. So the discovery of this rank ligand monoclonal antibodies and other novel drugs in the market shows the research is of the osteoporosis drug development is a fruitful area. And so this is how we need to clinical translation research employing newer therapeutic methods such as stem cell therapies, mRNAs, other new emerging therapies, and newer. But a lot of advancement has happened in the area of osteoporosis. But what all we need to do is more vigilant in at least screening and diagnosing this condition, and discussing with patient the importance of this disease, the diagnosing this disease and preventing the fractures, so that they are convinced to start these osteoporosis therapies. Thank you.
Thank you, ma'am, for such an elaborate discussion. So there is one query, ma'am. An attendee wants to ask that how to offset the risk of rebound vertebral fractures after stoppage of denosumab.
Yeah, very important question. I didn't go into detail of that yes, there is a risk of rebound vertebral fracture, which has been shown in the studies that once you stop denosumab, there is a risk. So there are multiple, in fact, risk factors for that as well. It has been shown that if you give a denosumab for just 3 years of duration, and then you switch over to the other anti-resorptive agents like zoledronic acid, then the risk of rebound is not there. So there are now the studies, data switch study, which have mainly focused upon this part, that if you give denosumab, stop for 2 years, and then give zoledronic acid, there they found there was no risk of increased rebound fracture. But this is still, there is no consensus on that. We have to go by clinically. If needed, we might have to just continue with denosumab. If we think that the patient is at high risk, we cannot afford to stop it. But if you think that you have given initial combined therapy with teriparatide and denosumab for 2 years, there is a chance that you can switch over to zoledronic. Thereby, you can prevent the new vertebral fractures.
Thank you, ma'am. I don't think there are any further queries. So this concludes the third MEND clinical update series. So now I invite Dr. Sunil Mishra, sir, for concluding remarks and vote of thanks.
Thank you, Dr. Rujul, for such a wonderful conduction of the MEND update 3. And if any comment from my colleague, Dr. Shafi, if he's there. Okay. The USP of our MEND clinical update always used to be in the quality of the talks, right? And the content used to be always top notch. And we always try to maintain that it should benefit your day-to-day clinical practice. Whatever the subject, whatever the topic we choose, we try to go into depth and try to simplify as much as possible for the benefit of the practicing physician. And we will continue to do that. And this was our endeavor in today's. This was wonderful. All the three discussion by our experts. Dr. Wazir in obesity, the use of GLP analogs, how to prioritize, what kind of the patient you are going to give benefit. And the second was Dr. Shyam Bansal, excellent deliberation on diabetic kidney disease. And last but not least by Dr. Parjeet on management of the osteoporosis and newer therapies, how it can help the people for minimizing the fracture risk and burden of the osteoporosis to large extent. So with that, back to you, Dr. Rujul. Any comment from Dr. Shafi, if you are here? Okay. Back to Rujul.
So thank you everyone for joining us in the third MEND clinical update. It was indeed an enjoyable learning experience for all of us. So I once again thank all the speakers for their excellent deliberation. Thank you.
Bye-bye. Good night.